Hello, everyone. Thank you again for joining today. It looks like we've got a good group of attendees here, and I know some others will continue joining, but we'll get started to make sure we can have as much time as possible for conversation today with our expert panelists. My name is Jake Loesch, and I have the privilege of serving as the Executive Director of Citizens League. I want to thank everyone for joining us today. A special welcome to anyone who's joining an interconnected conversation for the first time, and to all of our expert panelists for making the time to share their insights with us today. For those of you who aren't familiar, Citizens League is a 72-year-old nonpartisan nonprofit organization here in Minnesota, and we focus on civic engagement and have been building trust and connection across difference to work on public policy solutions since our founding in 1952. Our work today includes running the Capital Pathways internship program, creating paid opportunities for BIPOC college students to work with host organizations, and gain experience working in the legislature and public policymaking process. We also conduct public policy research and studies, and another big part of our work is hosting events just like this today, today's conversation. Deep dives into those policy topics that create educational opportunities and hopefully help you as attendees hear from a variety of perspectives and ideas. We're really proud and grateful to have been working with the Center for Rural Policy and Development on this interconnected series since 2020, focusing on bridging the rural-urban divides and exploring what shared challenges and opportunities we see across the state of Minnesota. Like Citizens League, CRPD is a nonpartisan nonprofit organization and focuses their work specifically on providing public policymakers and Minnesotans with unbiased information, research, and evaluation of issues specifically from that rural perspective. Kelly Ash is a senior researcher with CRPD, and Kelly authored the report today about nursing care in rural Minnesota. So I'm really pleased to welcome Kelly, and I will hand it over to him to get us started talking about the report and the research. Thanks, Kelly.
Thank you, Jake. I appreciate it. Jake, can you give me a thumbs up that you can see the presentation and you can hear me okay? All right, great. Thanks. And just want to point out the Citizens League again. Thanks for hosting us and always allow us an opportunity to present research and allowing panelists to come in and provide a little bit deeper dive on some of these things. So we released on Monday kind of I would say a numbers-oriented or data-oriented report looking at rural nursing facilities, in particular the beds that are available or at least their licensed capacity, what some of those trends are in rural areas. And for some of you that may be familiar with Center for Rural Policy, we used to do and change up our research agenda every year. We actually started a new research agenda process where we have set our themes for 3 years now. So instead of changing every year, we're doing a 3-year process in which we can really dig in a little bit deeper. These are our 5 research themes starting this year and going into 2017. So remaining resilient in an aging rural Minnesota, the future of rural access to well-being, the role of rural places and people in a shifting energy infrastructure and environment, funding local government in changing times, and a new future for rural childcare. This particular project falls under our remaining resilient in an aging rural Minnesota. And this is kind of the first report in which we see a series of reports coming out regarding elderly care in particular. So this is putting the numbers on some of the issues that we're seeing here. Today, we're going to go through 5 different things, and these are pretty short and brief, a lot of data here. We're going to talk about the demand, for the increasing demand for skilled nursing facilities, beds, the declining capacity in skilled nursing beds. Why is there so much decline? So provide some context into what's going on here. The role of what I could call non-institutional care, so assisted living and home-based care. What role are they playing in all of this? And then kind of what's coming up next, what to do. So let's look at demand for skilled nursing beds. So I used the profile of older Americans provided by the Administration for Community Living. And I wanted a special shout out to Anthony Schaffhauser, who turned me on to this at Minnesota Deed, who I'm going to be talking about a little bit later, who's got a great report coming out in December that I want you all to pay attention to. But I used the state demographer's population projections along with the current data on what percentage of these different age groups, particularly 65 and older, what percentage of them are in nursing facilities. And I kind of looked at that and said, okay, if they stay the same, if those percentages, let's say, stay the same moving forward, what will the projected demand look like? And so this is the demand across Minnesota. The peak demand in Minnesota is going to be right around 2047 with 37,234 projected demand. These are estimates, by the way, so don't hold me to it if we don't reach these numbers. But this is kind of what it looks like, right? We're going to see a real steep increase in demand. And we probably all know why that is. We have some significant demographic changes occurring in Minnesota. And again, this is a statewide issue, but these demand increases look different depending on rural and urbanness. So I broke out this demand in these projections based on this kind of rural urban commuting area. State demographer did this work in looking at what counties are like entirely rural, what counties are town rural mix. If you need the map on that, let me know. We can send it to you. But you could see for our entirely rural counties, we're actually expected to see peak demand in 2037, which is quite a bit earlier than 2047 for our more urban places. And our entirely urban 2055 even is still continuing to increase. And you'll see the differences in the demand in these slopes, right? So entirely rural areas, they're already feeling quite a bit of demand because they're quite a bit older already than our urban areas. But you could see that increase going to about 2037, and then we're going to see a pretty steep drop off where town rural mix, urban town rural mix, entirely urban, they have the kind of same increase, a little bit more of a plateau after that with no big steep fall off. So again, this is just kind of pointing to peak demand, what that's going to look like over the next few years. Peak demand is going to occur in rural areas significantly sooner. But again, this is a statewide issue. It's just that they look a little bit different, and the timeline at which these changes are going to occur vary as well, depending on rural and urbanness. And in the report, I actually have a county map too that gives a little bit more details by county instead of county groups like this. So if you're interested, check out the report on our website. So declines in skilled nursing beds. So we have demand increasing. So how are we going to meet that demand? Well, that's a good question. So here we have number of skilled nursing beds. And I apologize. These should say nursing facility beds. I forgot to change all of this. But just think of nursing homes. We kind of interchange these labels, but the number of nursing home beds has decreased by a third since 2005 across Minnesota. So in 2005, we had 37,718 beds. By 2024, we've lost a third of those to 25,173. So a little over 10,000 beds have been lost across Minnesota. But again, that is different depending on rural and urbanness. So since 2005, our entirely rural counties have lost 42% of their nursing home facility beds, 40.4% in our town rural mix. And as we become more urban, a little bit less of a percentage. So our entirely urban area is about 29% of their beds. So again, demand is increasing. We're going to see demand peak a lot earlier in our rural areas, yet at the same time, we see the most significant decline since 2005 occurring in our most rural areas of Minnesota. So why? Well, I should say not why yet, but the one important distinction here is that there's two sources of bed declines. So you can either, let's say a county could lose beds due to a facility completely shutting down, so you lose all those beds, or it could be that a facility reduced the number of beds that they are licensing to be available. That's an option as well. And both occur across Minnesota. What that proportion looks like, again, changes depending on if you're rural and urban. In entirely rural areas, almost 60% of their bed reduction has occurred because facilities are closing versus 42% that have shrunk. It's the inverse for all the other types of counties where they had more of their bed declines occur due to shrinkage. So facilities reducing the number of beds they have versus the number of facilities that have closed. Why is that important? Well, if we have demand increasing for these types of beds, we're probably going to want to see some flexibility in facilities being able to put some more licensed beds into the field. But if a facility is closed, obviously they're going to be there's no way to do that unless you build brand new, which probably isn't going to happen in a rural area, or at least would be pretty rare. So again, it's that flexibility in meeting the demand that's going to be occurring over the next 10 to 15 years in our most rural areas of the state. So why is there so much decline? This is a good question, and I think it's a thing that a lot of folks are kind of confused by. So we just did some digging around. We did some just looking at policy, doing academic literature review, looking at how things have changed. And there's a lot written. Really want to pick up the University of Minnesota Public Policy Department, College of Public Policy Health. They have done a really good job of keeping track of this. Ann Henning-Barber in particular, or Ann Henning-Smith, sorry, in particular, a great researcher at the University of Minnesota, has really been keeping an eye on this stuff. I love her work. And really, there's two kind of factors that are slamming into each other as the primary reasons we're seeing decline. So the one is actually a long-term thing that we've seen probably since the 1980s, and that's the technological, financial, and policy changes that have allowed home-based care and assisted living to take a bigger piece of the elderly care pie. So just think of like all these changes have happened. Nursing homes used to take care of a pretty broad spectrum of, let's call them patients or clients, and that has shrunk because a certain proportion of those clients or patients are now being taken care of at assisted living facilities or through home-based care. These are good things. There's nothing wrong with that, but it's just the context as which these nursing homes are operating in. And then the most recent impact we've seen declines is because of workforce shortages. And this has been occurring probably since, I would say, mid 2010s, 2015, 2016. We started hearing about this more and more. Healthcare in general is facing significant workforce shortages, and it's really bled into nursing homes and their ability to staff their facilities. And that's really impacted their ability to have the number of beds available. Even if the bed is there and it's licensed, they may not be able to staff it. So that's been the more recent impact. And these two things are kind of slamming into each other at a particularly tough time in which demand is increasing. So it's really interesting. So just a little bit deeper on the long-term impact. So in the 1980s and the 1990s, there was this negative perceptions of skilled nursing facilities among consumers, having shifted their preference to receive care at home or in assisted living whenever possible. And that kind of perception really started and instigated this whole change regarding how policies and allowing payments and care to take place in non-institutional settings, which is not skilled nursing facilities, but assisted living facilities and home-based care. So you saw that shift kind of happen. There has been advances in technology that have made it easier to receive care in non-institutional settings, as well as assisted living communities and receiving care at home is traditionally less expensive than receiving care in a skilled nursing facility. This is largely due to, well, I should say that well, I'll talk about it here in just a second. So if we look at the business model change, and if we were to look at, let's say, the 1980s and 1990s, nursing facilities used to, like I said, take care of a broad set of clients or patients that had acute severe symptoms or less severe. I remember talking to an individual interviewing that had a lot of experience in nursing home operations. And he said, you know, back in the 80s and 90s, it was pretty common that we had patients and clients that had driver's licenses and were walking around and would walk to their meals and stuff like that. That wasn't uncommon, where now today it's pretty common where you would walk into a nursing facility and almost everyone's in a wheelchair, right? Like the types of folks and clients that are being taken care of in these settings are a little bit more acute, a little bit more severe, and more costly. And so regarding how that revenue and that business model works, that's really shifted. And so if we look at what it looks like today, again, nursing facilities still taking care of this acute and severe group, but assisted living and home healthcare has kind of shaved off that group that maybe didn't need the amount of thoroughness and depth of care that nursing facilities can provide, but so they can be taken care of somewhere else. But this has then impacted nursing facilities' ability to see revenues and operations work well. And this is a really simple representation. There's a lot of nuance here, and I'm not paying justice to all the work that gets done with all these organizations. So please forgive me, but I want to kind of portray these issues in a really kind of layman's terms so we can kind of get on the same groundwork here. Carrie Swanson, who is the CEO of Cornerstone Nursing and Rehab Center, serving Bagley, Fosston, and Kelleher, says cost of supplies are up, wages are up, but payments have not increased enough. Lots of rural facilities are small and can't cut any more corners or scale down enough to make the finances work. And this is all about that economies of scale. So all these nursing facilities have seen a decline in their population that they're taking care of, and the ones that they are taking care of are the most costly. And so those economies of scale are just kind of not working very well. And we actually saw that when we looked at the data. So each one of these dots is actually a nursing facility in Minnesota, along with what county group they're located in. And what this is on the y-axis is essentially their capacity, their bed capacity on the y-axis. And you can see this red line is the average of all the closed facilities, the average bed capacity, where the orange is the median bed capacity, right? Right around 50 beds. And you can see in our entirely rural facilities that are still open, they're right around those medians and averages, right? So again, it's the smallest facilities or the smallest capacity facilities that are closing the most frequently and are most likely to close. And so this chart just kind of shows, for our entirely rural counties, they do match a capacity profile that matches facilities that have struggle to make their financial situation work. And then getting back to the recent impacts, so the workforce shortage, this is the job vacancy. This is the job vacancies in each planning region in Minnesota for registered nurses, home health and personal care aides, nursing assistants, orderlies, and psychiatric aides, just the way the occupational codes work. That's kind of the group that I pulled aside. And if you look at the job vacancies, I mean, there's been some steady increases all across Minnesota, huge increase during the pandemic. We had a lot of job vacancies, a little bit of recovery since then across Minnesota. But again, these are crazy, crazy numbers. And actually I think it's Northwest and maybe even Northeast and Southeast, let's say this 1,564 job vacancies that are in these occupations in Northwest Minnesota make up nearly 15% of all the job vacancies in that region, that's just a crazy percentage. And so this is a really, really kind of, I would say, significant and critical data point to look at why nursing facilities are kind of struggling keeping their beds available. That's on top of the change in registered nursing and other care providers in 2005. This is the number of actual employees or filled jobs, essentially, in these same occupations. And you can see, whoops, sorry about that. You can see that in our planning regions, they kind of peaked in 2015, 2017, and actually been declining since then. So the number of people in these occupations are actually declining. So job vacancies are going up as well. So we really are having a really interesting moment. Seven County Metro continues to see some good increases in these occupations. Not to say that they're doing all that better, because I know they're having the same struggles to find workers as well. But it's particularly bad outside of the Seven County Metro area. This was one quote I got from an operator, said they're already not meeting the need due to workforce shortages. This person said, we are screening patients to make sure we have the workforce to meet their needs, and we are turning people away daily due to the lack of workers, just not able to meet whatever specific needs the patient might have. That was daily, this was up in a very rural area of the state. They're turning patients away every day. So the other side of this then is the access to non-institutional care. Not that these are substitutable. So I'm not going to sit here and say, well, if they can't find a nursing facility bed, maybe they could get their care met in assisted living. I don't think that's the case anymore. And I think a lot of people would argue that. But I do want to point out that elderly care in general, so not just the folks that need nursing facility care, but just folks that maybe need a little bit more assistance, are also seeing some challenges and struggles to this issue. This is assisted living access. So number of people age 65 plus per assisted living bed. And you can see in our entirely rural areas, there's actually 33 65 and older folks. This is as of 2024, 33 65 and older per assisted living bed. 22, 20, 15, it gets a little bit less the more urban we get. Another way I wanted to look at this was if we took all the loss of beds, so the total number of beds that have, let's say, disappeared or are no longer available, the total reduction in beds from 2020-24, how much does the current assisted living capacity make up for that loss? Not that these are substitutable, but again, to kind of get a sense of how bad it is, because I can't provide trends on assisted living because the state just started tracking this stuff not too long ago. So we don't have any trend data on this, or at least I didn't have access to it. So what that looks like in entirely rural counties, the assisted living capacity in 2024 didn't even make up 100% of the losses that we have had in nursing facilities. So again, it's not like we're losing all these nursing facility beds due to assisted living being available, right? Like that's not what's happening here. Whereas entirely rural areas, they are entirely urban counties, they have 820% of assisted living facilities makes up of the loss that they've experienced. So again, way more. And it just, again, points to really I think, contemplating what does access look like for our rural areas in elderly care. So a harder one is home-based care. And we have a couple panelists that are going to be providing some more depth on this one. These folks are really hard to track because we have folks that are, yes, they're registered businesses. Some of them are licensed, but it's not like a clean way right now to figure out what access looks like, because a lot of home-based care employers are actually headquartered in the Twin Cities. And so it can be really hard to know, like, do you serve rural areas? So I forgot to, I apologize, particularly to Kathy here. I got this data from the Home Based Care Association, who is a member-based organization that kind of advocates and helps out these types of organizations. I went on their member website, their kind of member database directory, and just looked up, and it's a really nice website. Go check it out. If you have somebody elderly, you can go on there and be like, okay, I live in Roseau County. I need somebody that can provide skilled nursing. Show me all the different businesses or agencies that provide skilled nursing in Roseau County. So I did that. I just did kind of a sample here just to take a look. And skilled nursing provider Roseau, there were 6 agencies that provided the service. Cook was 7, Swift, interestingly, 15, Houston 11, Carver 37, Rock 10, Kitson 7. And this doesn't even include the agencies that don't include Medicare and Medicaid, right? So there are some agencies now that are done with accepting those types of payments. So again, it's really interesting. Carver has 37 agencies providing skilled nursing provider at home in Carver County, where Roseau County has 6. Again, kind of points to what does access look like in rural areas for these types of elderly care. But it's really, really hard. I don't want anybody to say, oh, yeah, this totally proves it, because we really can't prove it yet. Some further research needs to be done on that. So what to do? So this was a research project that was not dedicated to figuring out what to do. We're not going to provide solutions on this particular report. But there are a couple things that came up during our interviews that we wanted to point out. And then we do plan on doing future work on this. The first one is the Center for Medicare and Medicaid Services. They are proposing some new staffing requirements that are going to put a pretty big burden on our nursing facilities to be able to provide the services at the kind of staffing requirements that are going to be set in stone here over the next 2 to 3 years. They're rolling it out in segments here. Look for a report from Anthony Schaffhauser at Minnesota DEED. In my report, I put in a link to sign up for their newsletter. He allowed us to take a look at his draft report. It's really, really fantastic, and it's pretty alarming in terms of what it could mean, in terms of how much some of our nursing facilities are going to have to staff up and try to find registered nurses and other types of orderlies to meet these requirements at a time when they're already struggling to fill those positions. So again, keep an eye out for that, because that's going to go a little bit deeper than we were able to. And then just recently, the Minnesota Nursing Home Workforce Standards Board, which was passed by the state legislature, really dedicated to, I think they had 5 main kind of rules that they're trying to set in place for workforce standards regarding nursing facilities. And again, the standards board, I think everybody I talked to said, yes, this is needed. This is a great idea. We want to support our workers. One of the issues is they are proposing a minimum wage for these staff, which I think everybody would agree is absolutely great. I think everybody believes and agrees that these folks should be paid more. But again, it feels like an unfunded mandate. And again, just talking to folks, looking at the data, there's some real financial barriers and financial model issues here that could really put particularly a lot of our rural areas in a really tough spot if minimum wages come through without any sort of funding to help them increase those wages. So those are just 2 things to kind of mull on while we dig a little bit deeper over the next year as we dig into this remaining resilient in an aging rural Minnesota. We're going to be doing some future research, try to get more into solutions. But at the same time, we have these great panelists that I want to turn it over to that I think can really put some meat on these bones regarding this data that we showed. And Kate, I'll turn it over to you to introduce the panelists. And thank you, Kate, and thank you, panelists. I really appreciate it.
Great. Thank you, Kelly. That's super insightful and a great way to kick off this panel with our experts. So welcome, everyone. Thank you for joining us for this important discussion on the future of elder care in Minnesota. My name's Kate Raditz, as Kelly mentioned. I'm with McClung PR. We're a public relations firm based here in the Twin Cities, and we've been able to work with the Center for Rural Policy and Development for many years, and also had the privilege to partner with Citizens League on this event. So we have a great panel of experts today to weigh in on this topic that will include digging into that report a little bit more from CRPD, but also just a broader conversation about what challenges we're facing in Minnesota for caring for older Minnesotans, both in rural and urban areas. So if all of our panelists, if you can have your cameras on, I will introduce you. So our first panelist, we have Kim Brenny from the Minnesota Department of Human Services, Aaron Hupert from Leading Age Minnesota, Kathy Messerly from Minnesota Home Care Association, Barb Jazorski from True Healthcare, and Jason Anderson with Sanford Canby Medical Center. A reminder that this is being recorded, and for everyone here, we have the chat open, which I see you've already found, and I see that you are already asking questions. So I'll ask my first question, then I actually will try to get to some of those that some people had questions while Kelly was speaking. So this first question I will ask for all of you, and it's possible you will have some overlap, especially based on what Kelly just talked about. But what are you seeing based on the field you are in and what you work on as some of the greatest challenges today when it comes to caring for older adults in Minnesota? Kathy, maybe we could start with you.
Sure. Thanks for having me. Happy to be here. I think it comes down to two things if we want to simplify it. It comes down to access to care, of course, which is caused by two things. We simply don't have the workforce shortage. We have a workforce shortage. We simply don't have enough people in the workforce. As Kelly was talking about the demographics, we have to remember how many people are over the age of 65. There are more people that are needing care now than there are people working. And so we simply don't have the bandwidth in the workforce. And then the other factor is the lower reimbursement. So what many people don't realize is whether it's nursing homes or home care, and I speak from the home care perspective, that if they're on Medicare or Medicaid, the rates for reimbursement are set by the government. So we can only pay salaries and wages that are under the reimbursement rates, because there's, of course, overhead, and I could go down that rabbit hole, but I won't, of all you need to do for operational costs. So I think based on the demographics and the low reimbursement rates, we simply can't pay the wages that are needed. And so it's difficult to draw in the individuals that we do have in the workforce.
Thank you. Jason, I'll go to you next.
Oh, good. Thank you. My name is Jason. I just a little bit of a landscape of where I work and what I do to paint the perspective of rural healthcare. So I work in Canby, Minnesota, which is a site that has a critical access hospital, clinic, long-term care facility, and assisted living. So kind of all services under one roof. Work for the bigger parent organization of Sanford Health and Good Samaritan Society. So we have many organizations dispersed throughout the state of Minnesota. And like Kathy mentioned, access is definitely an issue. Workforce is definitely an issue. And I think you'll hear that definitely repeated. As an example, we've had a registered nurse position open in our nursing home for 450 days. And, we need that. That's a long time to have a position open, and that's not unique to me. The other thing is access to transportation. When you're out in rural healthcare, that's one of the biggest things that you can think about is how are we going to get to residents to appointments? So in addition to the transportation, we usually have to send aide or a staff member with them to supervise them. So you're taking a staff member out of the building for maybe up to 8 hours per day. The other main challenge I just want to highlight really quickly is mental health. Our aging population, as mental health awareness becomes more popular, and we're seeing the need for mental health. We offer that right now via telehealth, which is a great luxury, but it would be much better to have these residents seen in person. And we just don't have the opportunity to do that. And thankfully, we have access via telehealth where many sites don't.
Thank you, Jason. Barb, I'll go to you if you can say hello and also give your perspective.
Hello, I'm from True Healthcare. We have a skilled home health agency. We have 3 skilled offices, as well as we have a sister organization which has about 20 home and community-based offices throughout the state of Minnesota. So I have had 20 plus years with home care and home and community-based services. So, and kind of the same thing is workforce shortage is probably the biggest, as well as payer reimbursement. Again, there's huge differences between Medicare and Medicaid, and agencies cannot survive if their majority of their clients are only Medicaid or Medicaid type payers, like the PMAPs. You cannot survive on that reimbursement. And as well as there's some regulatory things that, again, we can't change up our staffing models because it's regulated. So you need an RN to do certain things. We can't have an LPN. Sometimes we can find an LPN easier, but we can't because of regulations. So it's just a complicated issue.
Thank you. Kim, if you can share a little bit about your background and your answer to the question.
Good afternoon. Thank you for having me. I'm Kim Breddy from the Minnesota Department of Human Services. And prior to joining the agency, I spent my entire working career on the provider side of things for the most part. To echo what the rest of the group has said here, we have a math problem, right? People are living longer than ever, which is great. But the workforce we rely on them for this care has shrunk and continues to shrink. Being in this industry my whole career, I feel like we've certainly had other peak times. I remember 24 years ago working for the Board of Social Ministry and bringing in nurses from the Philippines, recruiting nurses from the Philippines. And this feels to me, not that it's the same, but there's certainly some similarities in the level and depth and scope of the severity of this. So I think, one of today's greatest challenges is getting people the access to the type of care they need, when they need it, and then geographically where they prefer. Having my father in a nursing home last year, it was important to us that we find a home for him that was close enough for my mom to visit him at. And so there's probably enough places to get care in Minnesota, but is it geographically reasonable? Is it geographically preferable, to the point of some of the information that Kelly has shared with us? And then I think the other challenge is the cost of this care. The average cost of a semi-private room in a nursing home is over $133,000 annually. And I just think that financial resources or the lack thereof can be a barrier to care, or at minimum, something that may influence where you seek care.
Thank you. And Erin.
Hi, good afternoon, everyone. So I'm Erin Hubert with Leading Age Minnesota, and I certainly echo what the other panelists have said, but I, as perhaps a different flavor, a different take, would add to that I think Kelly covered this in some of his report. We are an aging state, and I think we're a little bit ahead of some of the other states in our nation in terms of getting older faster. Certainly in rural Minnesota. And I think what that tells me is there is an opportunity and an obligation by our elected leaders, by our civically engaged public to really reframe the priorities of the state of Minnesota and put a bigger focus on what it means to be an aging state, and to ensure that our policies and priorities are in line with what that vision and what that seriousness means. I think we have a lot of really thoughtful leaders who are going to be joining the legislature in 2025. And so this is really an opportunity for them to think boldly and differently about how we care for a growing population of older adults.
Thank you. And I mentioned as Kelly was presenting, I saw a bunch of questions coming in. I don't know if I'll get to all of them, but since they're kind of continuing to come in, I do want to go back to a couple of them before we move on. So one person asked, where do patients go or people go when they are turned away? Do they move? I think they're referring to in rural Minnesota. Do they move to the metro, or is anyone tracking this? Maybe Erin, Jason, or Kim, can any of you weigh in on that?
Yeah, I'm happy to start. So we do track some of that data at Leading Age Minnesota. Some of it is more quantifiable, but a lot of it is anecdotal. And so we have had several instances in the last few years in particular where individuals who are looking to come back home, say to a rural community in southern Minnesota, are not able to do so because the workforce needs aren't there. And so instead, they have been rerouted and then placed at a nursing home for their recovery in St. Cloud. And so this was an individual in my example where their family was then traveling for almost a year between southern Minnesota and St. Cloud to visit that individual on their path to recovery. So we can talk cerebrally and academically about these challenges, but they really mean something to those families and those residents and those patients as they recover.
Thank you. Another question asked, do you know what organizations are looking at solutions to this problem? Kim, maybe can I ask you that question? Oh, there you go.
I think I tend to think that might be something some of these organizations or Leading Age might be able to respond to. I don't have a way of collecting or them reporting to me, what they're doing or looking at or looking for.
Kathy, or does someone else able to weigh in on different organizations? Obviously, you're all trying to be part of that solution, but I don't know if you can call out other organizations involved, or maybe they're wondering how to get involved.
I'll just share one of the unique examples that I have run into, and it has been done in the urban area. So I'm not sure if it's available in rural, but I'm going to toss it out there just in case. I'm not sure if the rural area has the community clinics that we have in the metro. If any of you know, feel free to shake your head one way or the other. But we had one of our agencies teamed up with a community clinic. And what they did is the PCAs who don't have any medical experience, it's considered a non-medical position, but they were able to be the eyes of the doctor in the home and be able to call out if anything was happening. So homemakers, PCAs, even home health aides, they can be catching things that are happening in the home. And while they can't do anything about it, they can share the news, share the information, whether it be with a medical doctor, with their agency who contacts the medical doctor. And often it can really catch things and be more preventative because they're catching it early. So that's one of the things that we can look at is how can we really have our eyes on the patients and know what's happening. Some telemedicine can also do that. So you could have them checking their vitals and put it in a system, and the home care agency can actually be catching it. So if someone has heart issues, cardiac issues, you can know if they're gaining weight day from day. So they put in their weight every single morning, and you can see that, oh, perhaps they're gaining weight, they're gaining fluid, and we need to get them in. So those are a few things that I can offer.
Thank
And
you.
Kate, I'm happy to also add, Kim kind of referenced it, but Leading Age Minnesota is, I would like to argue, an organization that is coming forward with solutions to those elected officials because of all of the reasons that have been mentioned today. We advocate alongside one of the sources that was used for data in this report. It was referenced Care Providers of Minnesota. So the two organizations together have come forward year after year with a legislative proposal to address some of these very real challenges. One very specific example, the last 3 years, we have introduced legislation for the legislature to provide funding that would have afforded about a $5 an hour on average increase for those workers in nursing home settings, which would go a long way to helping providers remain competitive in a tight labor market. Unfortunately, the legislature did not have the means or the willingness to see that particular legislation signed into law. So we continue to make the case that that's something that needs to be done in 2025.
Thank you. And
And
Kim, go ahead.
We do the same from the home care perspective. I was looking at kind of non-legislative issues, but the bottom line is we all need to have the rates increased in order to increase the access to care.
And I was going to say, we've already brought up, the financial hurdles. I think someone mentioned the regulatory hurdles. Can you talk a little bit about, are there particular areas where policy could provide more support? You mentioned $133,000. I think you said the average cost annually. How are families, how is this being paid for, and where could policy provide more support?
So the majority of the total days annually in nursing homes in Minnesota, it runs between 50 and 55%. So the bulk of the days for people in nursing homes are paid for by medical assistants. And then the other days are paid for either by Medicare. Medicare's payment is usually pretty limited. I think they're paying on average about 25 days per patient stay. So it's not like you go in and Medicare pays for the first 6 months. We're not seeing that. Private pay, veterans benefits, long-term care insurance, some other, insurance policies, workers' comp, makes up the rest of it. The 133,000 was the average a few days ago. It fluctuates a little bit each day because nursing home rates can change from time to time for various reasons. But the cost of that is based on the rates that the Medicaid program sets and that pays to these nursing facilities. And that is defined in statute, which is largely, it's value-based reimbursement, which is largely a cost-based reimbursement system. And so as costs continue to increase, the Medicaid rates will continue to increase. And then we have a law called the Rate Equalization Law, and there's 2 states in the country that have that. Minnesota is one of them. Although I feel as though our rate equalization law has a loophole in it the size of a barn door. So the rate equalization law says that the private pay rates have to be what the Medicaid rates are. And so the state agency is setting the Medicaid rates, which means we generally regulate, you could say, the private pay rates. However, if you are a private pay person in a private room, most facilities are able to charge an additional amount per day called the private room differential. That is above and beyond the amount that the rates that the Medicaid program sets for facilities.
Thank you. And in this, go ahead, Jason.
To add something to that from regulatory perspective, I think we want our loved ones to be safe. There's no question about that. At the same time, there are many mandates and many regulations that could probably be adjusted, and it would take less time for the caregivers, and so it would save them money. And so it'd be much easier to have a better bottom line. So a couple of examples is at the federal level, they mandated electronic visit verification for all of home care, but there was no funding for it. So we have several unfunded mandates. Another one that we're all facing is the earned sick and safe time and the paid leave that's coming up. While we support those, there's no funding. And when our reimbursement is so low, it really is adding more of a challenge to the bottom line.
Kate, I was just going to add, kind of to expound upon from a provider standpoint that Kim was mentioning. One thing that I want to highlight is our payment is delayed. So for example, I use the common, we go out to the grocery store and buy milk at, $4.50 a gallon, what it is today. And we're not technically getting reimbursed that for 18 to 24 months down the road. So our cost and payments a little delayed. So just so the public understands that perception a little bit, that's, just how it works with all the audits and reimbursement and things like that. So that's why we're challenged. We're not really paid based on our cost in real time. It's a little bit delayed in that aspect. Another couple comments in regards to regulation. There's licensed practical nurses and there's registered nurses. LPNs are just a great asset to a lot of the aging population services, but they're not recognized, I don't feel, in the way that they should be. For example, in an assisted living setting, they have to, each resident has to have an assessment quarterly. The LPN is not allowed to do any of that type of work, and it's reliant on the registered nurse. And as I already mentioned, it's very challenging to find registered nurses in that, in the rural community. In addition, there's also some federal mandates coming forward, potentially from CMS, allowing our kind of putting restrictions on certain hours per resident per day of staff time, whether that's registered nurse or aides or different other staff. They aren't giving credit to that LPN kind of at the level that they should be, which is just disheartening, because that's a professional position that we should be recognized. So I think those are some ways that we could see a little bit more flexibility, some individualization at each site level.
Aaron and Jason, we have a question from KTTC in Rochester asking, with the decline in capacity of nursing care, has there been a significant change in nursing home rates over the years? Is there a year that saw the greatest change? Are these rates projected to increase or decrease in the coming years? Jason or Aaron, if you maybe could weigh in on that.
Yeah, this is a really important question, so I'm glad that it was asked in the chat. I think Minnesota nursing homes, as a general rule, and I'm going to say that very specifically, have done everything they can to invest every available resource into, in particular, wages and benefits as a means of recruiting, keeping staff, allowing residents in Minnesota to get placed into nursing facility care as they may need. So we will see, on average, reimbursement rates go up over time for nursing homes. And by that same truth, I would also argue that expenses have also gone up pretty significantly in the past few years. We may not remember the days of needing to don PPE, personal protective equipment, in the same ways that we maybe did 4 years ago, but there were a lot of operating expenses that our providers had to really go above and beyond in terms of purchasing. And so I don't know that it is fair to say that because the rates have gone up, that providers are doing well. I think the report that Kelly has outlined indicates that many of them are still operating on a very slim margin, if not operating at a deficit. Rates have gone up, and there's a lot of evidence to suggest that we have a lot of providers who, when you look at their individual financial position, are in a really vulnerable spot.
Jason?
Thanks, Aaron. Just to add a little bit to that, we care for people. So we're very compassionate because we're caring for those residents, the aging population of Minnesota. But as an administrator, I'm compassionate about my employees as well. So like Aaron said, we try to recognize the hard work that they do. If you wanted to ever spend a day with them, the aid work, the nursing work is, I'll arguably say, some of the hardest work in the healthcare industry. And so we really want to compensate for this. And so naturally, then the rates will go up. But I think the supply costs are going up at a much higher rate than we've seen historically. And so that's another challenge for us to be able to honor, recognize that. The other cost that we've had to defray is the aging buildings. I operate a building in Canby, Minnesota. That's 1960s model. It's old. The bathrooms are very, very small. Almost can be, a lot of times we have to use a larger bathroom down the hallway for the residents because they can't actually negotiate or move around the bathroom. And so I think in addition to kind of the rates talking about, we may, we don't have the investments in our buildings and our infrastructure or haven't been able to keep up with that. So in addition to Aaron saying, we're already at a loss, we can't expand or probably renovate our buildings or build new buildings that the new generation of aging people in Minnesota are going to require.
Have another question, I believe, from the media, a member of the media. Hearing some speculation that the new Trump administration could make some changes, including perhaps gutting that CMS RN requirement for certain nursing home positions. Does this group expect any significant changes for better or worse with the change of the new incoming administration? Aaron, are you able to answer that?
Sure. I can certainly start. I would welcome others if they have other things to add. I'm not going to speculate on what an incoming administration may choose to do. I will say Leading Age Minnesota has been on the record and been very public about a desire to see that rule rescinded, either through congressional action or administrative action. We believe it does irreparable harm to Minnesota's access to care, particularly in rural communities. And I'll just give you an example of why we think that is true. Based on the final rule that came from CMS, only 13% of Minnesota's nursing homes would be able to qualify for an exemption from one of those mandates. The RN mandate would be an example. And where that really matters is it would define counties like Becker County or Otter Tail County or Norman County as urban under the rule. And I don't think anyone who lives in Minnesota would think that those three counties are actually urban. They are very clearly rural, and the consequences of how this rule would play out for those communities and for people who live in those communities is really significant. So I'm, again, not going to speculate on what an administration would choose to do, but we, from an advocacy perspective, believe that rule needs to be rescinded.
Thank you. Kathy and Barb, question for you. You know, the report talked about this shift we are seeing, a little bit of this shift of people also exploring alternatives to nursing homes. You know, do you hear from people about why they are doing this? What are you hearing of why we are seeing that shift?
I guess I'll start first. And what we're hearing is people, again, don't want to go into nursing homes. Again, the perception, a negative perception is still very much out there. You know, my in-laws are examples. They have been hospitalized, and the first thing they said almost on admission was, I will not go to a nursing home. I mean, so they're already worried about that. Another reason is the cost. If they don't qualify for Medicaid, they don't have long-term care insurance, it's very costly because for Medicare to pay that 30 days or whatever, you have to have a qualifying 3-day stay. I mean, it's just very difficult. And so a lot of them, just because of cost, so they choose to do the home and community based. Plus, people want to be in their homes. I mean, they want to age in place, and that's very much what people want to do. So I'll let Kathy talk now.
Thanks, Barb. You hit on a couple of really important points. And I think that's one of the things we hear is they want to be in their home. They want to be where they're comfortable. If someone is starting to have dementia, they don't want to have go through a change because that'll make it all the more difficult. The other thing which touched on, I think it was Kim, but I don't remember, that touched on earlier is you may not have a facility, whether it be assisted living or nursing home, near proximity to you. So my mother went through this. She had to leave her small town and go to a neighboring town in order to go to assisted living. And then she wasn't where her friends could walk and see her, or if they were still driving, it just wasn't as convenient. And so that's really hard for people who have grown up in one community to have to move. And coming from rural Minnesota myself, I know that many of them have closed nursing homes. My mother ended up in a nursing home. It doesn't exist anymore. And so that becomes really difficult, and they want to be close to their family, friends. And it's also, they heal better if they're in their comfortable environment. Sometimes they're actually living with family, or at least really close to them. So that's the other factor in addition to what Barb shared.
Also for Kathy and Barb, this question is in the chat. How can we do more upstream to support people remaining in their home? What types of things you recommend? Providing more help to unpaid caregivers, PCAs, etc. Kathy, I'll start with you this time.
Okay. And Barb can talk a little bit more about the PCAs. I don't remember if Barb's been doing so many different pieces of care. Do you do the PCAs now too, and you can cover the families, or you're not doing PCAs anymore? Okay, so I'll let you cover that. We really need to, I talk about this when I'm in a large group of folks that are doing elder care from a variety of organizations. And the paid caregiver is so critical. You know, if we expect, some people say we should be like the other countries where the families take care of their loved ones, but we tend to be in a 2-person income. I mean, that just tends to be our culture. And so if someone has to give up their job to go care for a family member, it significantly cuts back on their income. and they are not able to be paid. There's an exception that's made for PCA that Barb can cover, but I think we do need to really value family caregivers, and we don't have a mechanism to do that at this point.
Barb, is there anything you wanted to add?
Yes, under the PCA service line, family members can get paid. That has been a more recent change thanks to the pandemic. But again, the reimbursement is not enough, and they can work at McDonald's or any restaurant or retail and get either more, or it's a lot less strenuous, stressful job working at Kohl's versus, taking care of a loved one, and if they're not, their family members, again, they can work anywhere. It's just easier to work at Kohl's versus taking care of someone who really needs the care. It's hard work taking care of people.
How do the challenges we're facing here in Minnesota when it comes to elder care, how do the issues here on this issue compare to other parts of the country? I mean, is this a problem unique to Minnesota? Where do we sort of rank I hate to say rank, but how are we doing compared to other states? Or is this a problem everywhere with where we are at? Kim, can I ask you, or if there's, go ahead.
Sure. So I can only share, things that I have read or have seen. But my understanding is that we're not the only country in the issue or state in the country that is facing this issue. I know there was a Kaiser study published earlier this year that had a number of various national nursing home trends from, I think, 2015 to 2023. I will say that while they showed a national trend of decrease in nursing staffing, Minnesota reflected a swing in the other direction. So I think, in some regards, that we see our occupancy running a little bit higher than the average in nursing homes. And we see a little bit of an increase, again, for this time period from this Kaiser study that was published in January. We're seeing, some little bit of differences, but certainly we're not alone in having concerns about access in rural communities and facing the staffing challenges.
I can speak to a little. We have home and community-based offices in 6 different states besides Minnesota, and every state is struggling with it. And actually, the states that we have offices, probably Minnesota is sitting the best as far as trying to be more proactive. Again, some of the other states we work in are even more difficult than Minnesota. So,
very interesting. Thank you.
Add that I think Barb's exactly right. The only difference I see is in the states surrounding us, many of them have much higher reimbursement rates.
Mm-hmm.
That kind of goes into, I had a question written down about, we've talked so much about the challenges, right? And we'll dig more into that. But, what are we doing well then? I mean, we must be doing some things well, right? Even with these challenges. Can you elaborate a little bit on that? Especially if other states are maybe having it a little harder even than we are?
I can add a little bit just from a provider standpoint and just really at the local level. Our goal is to provide great quality care, whether it's in that home setting, whether it's in that assisted living setting and our skilled nursing home setting. So unfortunately, sometimes this sounds negative, but we have to say no in order to maintain that. And us as administrators and providers, we want to continue to maintain that great quality of care. So that might be delaying an admission or sending them outside the community because we don't want to jeopardize other people's care or quality. The other thing, we know that hospital, if you ask a new college grad and they're a registered nurse, where do they want to work? It's probably in the emergency room, pediatrics, surgery, ICU, something like that. Those that are a little shinier objects, for lack of better words, versus the home care and the assisted living and nursing home setting. The state does have some reimbursement for college tuition, and each individual site also has different programs, like Leading Age Minnesota, to provide some support for people that are going into aging services careers. And something that we do locally, I think it's very important to get youth involved in healthcare at a young age. And about a third of our CNAs are high school and college students. They may only be able to work 24 hours a month, or they might have to take a 3-month break off during their college, but they may be able to help us 40 hours a week during their, when they're at home from college, or when they're not playing basketball and not doing school, they might be able to work for us a couple weekends a month. So I feel it's really important to get that youth involved. Hopefully they'll have a great experience, because we know that people that come into the assisted living, nursing home, and home health and hospice settings, they usually are pretty passionate and they stay with us as long as they get, familiar with that work.
And Jason, you talked about, getting involved with youth early on. Both Jason and Aaron, what other strategies are being explored, or do we know could help in recruiting and retaining staff?
Kate, thanks for the question. I mean, I think not to beat a dead horse, but clearly one of the most important things we can do is ensure that people who work in this field earn a family-sustaining wage. And that really is a task that our state policymakers have to also acknowledge and prioritize. But I think beyond that wage imperative, I always appreciate that Minnesotans are incredibly collaborative and incredibly they are willing to use their creativity to solve problems. And so I see a lot of our nursing home providers relying on volunteer programs to help support those staff, on using grants for volunteer caregivers to provide some of that respite, in using adult day services and some of those home and community-based services. And I think, I'm seeing it in the chat a little bit, but it's worth reinforcing. We are very troubled by this growing trend of individuals who don't think that they can afford nursing home care or assisted living care or anywhere along the aging services continuum without it impacting their children's budget or their older adults' budget. Leading Age Minnesota did some public opinion research about a year ago. And one of the most troubling findings to me was there was this expectation, 87% of respondents, and again, this was representative of gender, age, geography, and political ideology. They had an expectation that you should be able to have care within an hour of your home community. I think that means a lot to somebody in rural Minnesota. It means something probably different in rural Minnesota than it does in metro Minnesota. And not only do they have that expectation, but up to 50% of respondents said that they would reduce their work hours or leave their job to care for an older adult if they couldn't find that access within an hour, as opposed to trying to place that loved one more than an hour away from home. And that has a lot of implications for the vitality of our smaller communities. It has a lot of implications for the economy when we're in a tight labor market. And so it's in the chat, and I just wanted to call it out because we're seeing a lot of evidence of that too.
Kate, one other thing I know, New Americans are potentially a solution. I know Kim mentioned from the Philippines. I think you mentioned 24 years ago. The unfortunate part about getting newer Americans here is it takes a long time. A recent example, we did recruit 2 nurses from the Philippines. It took us 2.5 years to get them actually on the United States soil. Unfortunately, they were in large metropolises in the Philippines, and rural healthcare wasn't for them, and they quickly moved on to a larger city. So I think there's about a 50% retention rate of international RNs. Don't exactly quote me on that, but that's approximate. But that is one solution. And I know Leading Age, along with some recent grant funding dollars from the state, is investing in kind of a new program outside of the Philippines to try to expand kind of our depth and going kind of to the African area to hopefully get new Americans here to help us solve some of this workforce solution.
And Aaron and Jason, another question for you. You know, the report talked about the term unlicensing beds. Can you explain what that is and how that impacts availability?
One, I guess I can give an example, and Aaron will be able to give more definition. But in Canby, where I work, roughly 10 to 12 years ago, we were licensed for 75 beds, meaning we paid for a license per bed at that state level. We are currently now at 48 beds. So if you do the delta there, there's a great reduction in the number of beds. And so we unlicense beds or delicense beds. Because we are not able to mostly staff them. And, sometimes there's some access issues as well. But Aaron, I'll let her expound upon that a little bit.
Yeah, Jason said it pretty simply and pretty right. There's really two ways a nursing home can think about license. They can close, permanent closure. We've had about 26 of those happen since 2020, not exclusively, but a lot in rural Minnesota. Or they can put beds on layaway, which is that temporary closure. I would argue though that it's not this like highly dynamic resource that a nursing home can say, we'll use it on layaway tomorrow, but we'll put it online next week. Like it's a much more thoughtful, prolonged process, and due in part to our reimbursement system, due in part to these underlying staff problems. The vast majority of the time we see a nursing home, when it chooses to put beds on layaway, more often than not, that is a long-term solution, not a dynamic short-term solution. There are very few nursing homes that have been able to bring back a lot of their beds on layaway, which just continues to reinforce these access challenges that we see.
Thank you. Kathy and Barb, what role do you see for alternative elder care models, such as in-home care, in alleviating some of the nursing home capacity issues, knowing that not everyone is necessarily able to do that, right? That they may need more care than that. But I guess what role do you see going forward in being part of that solution?
Well, as far as what we see in our agencies, again, a lot of times families and clients will do home care till they can get into a local facility. Because again, although it may not be the best solution for their loved one, it's better than they're going to be 2 or 3 hours away. So they just kind of make do. And again, depending on their type of insurance, sometimes they're making do with really very little resources. Again, Medicaid and VA, again, are looking at their budgets. And again, a lot of hours have been cut for our Medicaid type clients. Our VA clients, again, have had cuts, going from 20 to 30 hours a week to maybe 6 to 10. It's, but they just make do. So I'll let Kathy talk further.
I had to get myself off unmuted. It's really difficult. It's so challenging for all of the families, and it's going to really vary depending on what their needs are. So I think some it's feasible to have a family member. I know I saw some in chat too, and I totally understand. My family did not give up our jobs to care for our loved ones, and we don't expect everybody to. Some families are able to do that for short term while they continue to look and fill the gap. There's the PCA program is the only one that you can get paid. As Barb noted, you're not paid much. There's very little reimbursement there. And I think we just really need to look at each individual and what their need is. So nursing home may or may not be the appropriate one. And I think we so often say, this is where you're going to go. And we don't stop and think about what they need and what they want. We late in the pandemic, we worked with MDH. I think most people don't realize how much you can do in the home. So one example we had is we worked in the St. Cloud area, and we were able to discharge clients to home care, and when the hospital was in desperate need to have more beds open. And they were surprised. I think everyone was surprised, including the physicians, on how many people could be transitioned to home care. There's actually a program called the Home Care Nursing Program where you can be cared for 24/7 in your home. Now, that's often used for pediatric patients where they're trying to get home to be with their families, but it can also be used for any age. There's no age limit to it. And so I think just being able to know what all the options are, I actually think one of the things we have to do is we need to do an awareness campaign, letting seniors know what's available, letting them be able to pick from the options that are available, and at the same time, building awareness about the careers. I know Jason talked about bringing in the younger people, and we often go out and talk to nursing colleges, nursing programs. And we talk about if they're in the nursing program, or even we talk to folks with the HOSA program, the high schoolers, and say, now's your chance to be either a CNA, a PCA, a homemaker. Now's your chance to try it and see if you like it. And if you do, this can be a pipeline for you. So I think we have to build awareness for the careers, and we also at the same time need to build awareness for our elders.
Thank you. An interesting question came in the chat about long-term care insurance. Asking, and I don't know if any of you know this, but asking what percentage of patients have long-term care insurance, and is there a point where it's too late to purchase it? And if you could also include a little bit about the cost factor in people deciding if they'll purchase that or not as well.
From an operator perspective, it's very rare that we're seeing long-term care insurance at this point, and the reimbursement is pretty minimal. So we don't see a lot of people coming in with that at this point anymore.
This is Kim from DHS. I can tell you that we collect payer source information on an annual basis. And the long-term care insurance falls into what we call other. So that's the workers' comp, maybe someone who's younger going in with, some workers' comp injury or something. But it also includes long-term care insurance. And that percentage is very low. So it's a very low percentage that we're seeing. And from what we have seen, it's not we're going to pay every day 100% for 2 years of care type of thing. To Jason's point, it's limited. So it's limited either in the amount that they're going to contribute per day, or very limited in the duration, or a combination of the two. But I don't have current plan cost information or rates available.
I don't have rates available either. I can say anecdotally, I think there's few, probably very few. My aunt happened to be one of the fortunate that got on the bandwagon soon with it. And she had such a good policy that it did cover her home health care. But that's pretty rare, I think.
Thank you. Thinking this maybe is a question for all of you, could technology and telehealth be used in any way, or is it already used to enhance caring for older Minnesotans, whether it's in nursing homes or supplementing in-person care? Has that been explored at all? We talked about the mental health aspect as well.
I could certainly start with the in-home care, and then I know there's a lot being done, probably even more in the nursing homes. Remote monitoring is something that a lot of people aren't familiar with. I actually worked with that before I came to the Home Care Association. You can put sensors in people's homes. A lot of people don't want cameras watching them in their daily lives, but sensors don't have a camera on them. And you can put them where it's critical. So if someone has dementia, you could put a sensor on the front door. And if it opens at 2 a.m., rest assured you need to be following up with them. And it alarms whoever you want to be getting the notice. You could put it on the cabinet where their meds are kept. And if it doesn't open at the time they're supposed to take their meds, then someone's alerted and knows that they're not taking it. So that means a nurse doesn't have to go in as often. The other thing that I'd mentioned earlier about the cardiac failures is you can have them weigh themselves, and the vitals just automatically go to the agency. or to the doctor, but we use them in home care for going to the agency. And so that can help monitor. I think there are other ways that we can start using more technology. There's more and more options. The other thing is technology is, the people think about the I'm okay button or the little button you can push, but it can be on a smartwatch now, just so that if you fall, someone's going to know about it. And then nurses know whether or not they have to go out and do a visit or if they cannot do that visit. So that really helps in the in-home care side of things.
Yeah, I think Kathy is exactly right. We are trying to use all of the resources we can, and that includes technology. I think I've seen it to do some of the things that Kathy's mentioned, monitoring risk for fall and trying to help care plan around those risks for falls, using some predictive analytics around chronic conditions and case management. And I think as much as we would like to use those things, I think there's still two important notes that I would contribute. One, we have to have a regulatory system that supports the use of that technology. And two, we have to have the resources to pay for that technology. And so both of those things are kind of part and parcel with the tech itself.
One thing I just want to mention that our organization is working on, and it's not down to the level of the nursing home, but we're trying to using artificial intelligence to help reduce the documentation load. So if you would go in to see your provider, basically they're recording that visit and extrapolating just the important data. The AI is able to do that to write their note. So they're not spending as much time documenting, they're spending more time with the patient. And I think that would be a great thing for all of the different professions on this call because of the required assessments that are required on a quarterly basis, if not more often in home health for sure. If that type of information could be received, put into the computer and documented, that would be a very important step because from a regulatory standpoint, we need that. From a payment standpoint, we need that. But our nurses, our aides, they want to be spending time at the bedside or, in these people's lives, actually providing that nursing care. And, an admission into the nursing home could take all day for the assessments to be completed. If not more or longer when you combine everybody's. And I think that would be a great time-saving technique, but it's costly. And so to integrate that, fortunately, like a large health system that we're integrated in, that's a great, we can do some things like that and be a little more flexible, but these small standalone organizations are going to have bigger challenges with that.
As you can tell from the comments, people are very passionate about this issue because it's their families, it's their loved ones, or they themselves are experiencing these challenges in some way. What do you want people to take away from this conversation in terms of what can and should they be doing? What is effective for someone watching or who reads about this of what should they be doing or can be doing to be part of the solution? And anyone, any of you feel free to chime in.
Oh boy, do we have another hour to have a conversation here about this?
We don't, but I wish we did.
I'll sum it up very quickly. The passion that we're seeing on that chat is just heartwarming to me because we do have the attention of the Minnesotans. I don't think that was there just real recently, but I think some of the pandemic, unfortunately, we had to have that, but gain some attention to these areas that we're talking about today. We still need more, though. This is definitely not enough. We need all the aging people of Minnesota. At some point, we're all going to age. We are doing it every day, and we need to be able to keep up with that. And pre-planning is very, very important. A lot of times we have these conversations where someone will come to the emergency room and they can't be admitted because there's no criteria for admission into the hospital. They need long-term care, and they're making a decision about the remainder of their life in a matter of 10 minutes. And so I think it's really important that we look at that pre-planning piece. But secondly, like I said, everybody promoting long-term care, whether it's in jobs, whether it's supportive at legislative levels, or just speaking these stories out is very important.
Yeah. I was reminded that, our elected officials they are just like all of us. They come from different professions. They come from different life experience. And so I have maybe two calls to action to offer. One, if this is something that really moves you and is something that you are passionate about, I would consider maybe putting your name in the hat to run for office someday, either at the local level or the state level or wherever it may be. There is one member of the legislature that has experience in a career in long-term care services, specifically nursing home care in this case. We have a lot of teachers, we have a lot of insurance brokers, we have a lot of folks who are lawyers serving in the legislature, and they all bring in a really important perspective, but we only have one who has a career working in long-term care, and we could always use more. So would encourage folks to think about running for elected office. And if that is not for you, I would really encourage you to ask your elected official, state senator, state representative, local county commissioner, or city council member, how they are thinking about representing the needs of a growing population of older adults.
Kathy.
Those were both absolutely right on. I'll just add a couple of points. I'm right with Aaron. Please know that your voice matters and do contact your state representative and your senator. They need to hear from you. We can go out and lobby, but they really want to hear from the people on the ground who are experiencing it. So they need to hear your stories. It's most powerful to have a story to share with them because that's what really resonates. That's what they walk away and remember. A lobbyist that we work with actually remembers a story he heard when he was a legislator, and it's like 20 years ago. And he'll still tell you that story. So it's really, really powerful to let him know what's happening. And then piggybacking on what Jason said, the pre-planning is so important. Know what your options are. I have a friend that's just going through this because her husband has an early onset disease. And they went too late to look for nursing homes. And the waits are really, really long. So even if you think that you might not need it right away, get your names in for the facilities that are your first choice and don't wait too long. So know your options, be aware, pre-planning, and please speak up to your legislators.
Barb and Kim, any closing thoughts?
No, I have nothing to add. I believe Kathy, Aaron, and Jason did a great job. That's really what you need to do.
Don't have anything further at this time either. I'm sorry, I'm losing my voice as we've gone through today. It's been a really interesting conversation, and I'm really grateful that I had an opportunity to join in and listen to everyone's perspective today. Thank you.
And I want to thank all of our panelists. I know, again, as we've seen from the comments, people are very interested in this topic, which is great. So for everyone watching, I would encourage you, please keep an eye out for more reports from the Center for Rural Policy and Development. You can support Citizens League and CRPD by following them on social media, seeing what other events are coming up. We love doing this interconnected series. This recording will be made available. For any members of the media, feel free to email me if you have any questions. And again, thank you, panelists. Thank you, everyone, for joining. And everyone, have a great day.